is Martin Hoenigl. I'm an infectious disease researcher and physician, and I'm also serving currently as the president of the European Confederation of Medical Mycology. And today's video is about the role of cytokines for assisting in diagnosing invasive aspergillosis and also for treatment monitoring and outcome prediction. One of the problems when diagnosing invasive aspergillosis is that diagnostics don't work as well in patients receiving mold-active prophylaxis. And this is showing on this slide also for BL-galactomannan, which has reduced sensitivity in patients on mold-active prophylaxis. Here in the lower part of the slides, only 71% in those with prophylaxis versus 95% in those without prophylaxis with a cutoff of 0.5. So how do we diagnose invasive aspergillosis in patients with mold-active prophylaxis? The solution here really is combine biomarkers. We know all diagnostic tests have reduced sensitivity in patients receiving mold-active prophylaxis. You know, this is including PCR, this is including the LFT, this is including conventional culture. The solution here is really combine multiple tests and you will have increased sensitivity without markedly reduced specificity. But of course, this approach is not optimal. Another problem we are facing is that we don't have reliable biomarkers for treatment stratification and outcome prediction in invasive aspergillosis, particularly if serum galactomannan is negative. Here is a study shown by Juan Mercier and colleagues from Leuven that really show, if we have positive serum galactomannan, we have a good marker for outcome prediction and treatment stratification. But when serum galactomannan is negative, which happens quite often, we are currently missing a marker, and this is an important unmet need in the treatment of invasive aspergillosis. So considering these unmet needs, we should really give cytokines and immunologic markers a second thought. Studies have shown that Aspergillus species induce the helper cell, Dh1 and Dh17 subsets, resulting in elevated levels of several cytokines, and particularly also cytokines L6 and L8. Specifically in early stages of invasive aspergillosis, conidia are killed by local alveolar macrophages, and interleukin-8, which is also known as neutrophil chemotactic factor, is produced by macrophages and epithelial cell as chemoattractant for neutrophils. Also, during invasive aspergillosis, there's an increased release of interleukin-8 and interleukin-6 by A549 pulmonary epithelial cells. So what about these cytokines, interleukin-6 and interleukin-8, for diagnosis of invasive aspergillosis? There has been a nested matched case control study that really looked into the potential of these cytokines in hematologic malignancy patients. And what they found, as you can also see in this box plot, is that cases with invasive aspergillosis had much higher levels of these cytokines in serum but also in BL fluid compared to matched controls without invasive aspergillosis. However, it remains of course unknown whether these cytokines hold value for clinical routine in patients on mold-active prophylaxis and if there is an added benefit of cytokine testing in addition to, for example, galactomannan testing or PCR, because this was not addressed in this study. So a next study looked basically into a longitudinal cohort of patients at risk for invasive aspergillosis. This study was done at the Medical University Hospital of Graz in Austria, which is a large university hospital with 1,600 beds, and included adult patients with hematologic malignancy, suspected pulmonary infection, who underwent routine bronchoscopy. Those patients who agreed to be included in this study had same-day serum and whole blood samples collected at the day of bronchoscopy, and a total of 106 cases were included in the final analysis, including 11 cases with probable invasive aspergillosis, 32 cases with possible invasive aspergillosis, and 63 cases with no invasive aspergillosis. And what's important to emphasize in this study cohort is that the vast majority of patients, overall 80% and 10 out of 11 with probable invasive aspergillosis, had received above 2 defined daily doses of mold-active antifungal prophylaxis or treatment at the time of BL fluid and serum sample collection. So what did results of this study show? Basically, they showed that a serum interleukin 8 specifically, when using a very high cutoff, had very high specificity for diagnosing invasive aspergillosis with acceptable sensitivity. And when looking on diagnostic odds ratios, it was even superior to some established biomarkers for invasive aspergillosis, including the lateral flow device test, beta-D-glucan, or blood Aspergillus PCR. Also in BL fluid, interleukin 8 had some potential for helping to diagnose invasive aspergillosis, although here the BL fluid lateral flow device test and PCR were superior. So overall, the conclusion from this study was really that the optimal diagnostic approach would be a combination of serum interleukin 8 plus BL fluid lateral flow device test or BL fluid PCR, which when combined yielded in very high sensitivity and specificity for differentiating those with probable or proven invasive aspergillosis from those without invasive aspergillosis. So this may really be an approach for settings with mold-active antifungal prophylaxis. One of the things to consider with immunologic markers and cytokines is that they also may be elevated in other infections than invasive aspergillosis. And in a sub-analysis of these studies, we looked specifically into patients who had other infections, including infections caused by bacterial pathogens or Pneumocystis jirovecii or Toxoplasma gondii. And what we found here is that serum IL-8 and also serum IL-6 were significantly higher in those with probable invasive aspergillosis when compared to those with other non-viral infections, which emphasized that if used with a very high cutoff, they could aid the diagnosis of invasive aspergillosis. What about treatment monitoring and treatment stratification and the use of immunologic markers? In this study by Chai and colleagues, there was a trend observed in patients with invasive aspergillosis that if IL-8 and IL-6 and also CRP persisted during therapy with an antifungal agent, this was associated with poor outcome. You can see here patients who died due to fungal infection had persistently high levels of IL-8 and IL-6, whereas patients who survived had decreasing levels of IL-8 and IL-6. In another study, again from our team from Graz, but also in cooperation with UCSD, we looked into serial measurements of cytokines and cytokine kinetics in our data set of 106 patients at risk for invasive aspergillosis. And we also found that those who had increasing levels of IL-8 and IL-6 had a higher risk of mortality than those who had a stable or decreasing level of IL-8 or IL-6 over the first 4 days after diagnosis of invasive aspergillosis. Findings of these studies and also of other studies have been summarized in a very recently published review in the Journal of Fungi, conducted by members of the study teams and also members of the ECMM working group on immunologic markers for diagnosis and treatment monitoring in invasive mold infections. This working group includes experts from all over Europe who came together to advance this field. What you can find in this review is a comprehensive analysis of serum and BL fluid, interleukins, and immunologic markers, and their potential to be prognostic for mortality, to change with treatment, and to be elevated in invasive aspergillosis and other invasive mold infection. So in conclusion, highly elevated serum interleukin 8 in combination with a positive BAL fluid lateral flow device test or BAL fluid Aspergillus PCR may be highly sensitive and specific for diagnosing invasive aspergillosis in patients with underlying hematologic malignancy receiving mold-active prophylaxis. Also, the kinetics of serum interleukin 8 and interleukin 6 may hold potential for treatment monitoring and outcome prediction in patients with invasive aspergillosis. And this may be particularly valuable for patients who don't have a positive serum galactomannan and therefore don't have other measures for treatment stratification. Larger multicenter studies are needed to further investigate the potential of these cytokines for treatment monitoring and outcome prediction, and these studies are currently in the planning phase and underway and led by the ECMM. And with that, I want to thank you very much for tuning in with our YouTube channel ID in Motion, and hope sincerely to see you next time in about 2 weeks when the new video will be uploaded into this YouTube channel. So thanks for following us and tell your friends.